So I want to tell you about my views about how psychiatric drugs work and what they do to people. So first of all, I want to say that I think that some psychiatric drugs can be useful in some situations, but I think that we fundamentally misunderstand what they do. And that's what I'm going to try and explain. We need to develop a better, more accurate understanding of psychiatric drugs in order to be able to use them more carefully and for the greater good. I have just published a second edition of my book, A Straight Talking Guide to Psychiatric Drugs. The first edition was published in Spanish, that's Hablando Claro. But I've also put up the web link there of the article that Javier very kindly translated for me and published in the Atlas magazine, if you want to. And there are many other articles by me on the internet if you would like to find more information after this talk. Okay. So the first thing I want to point out is that there are contrasting views about psychiatric drugs. On the one hand, some people have described them as miracle cures, as drugs that transformed psychiatry into a properly medical specialty, and that transformed psychiatric hospitals into true treatment centers. On the other hand, there are people who suggest that psychiatric drugs are methods of social control or chemical restraint. Antipsychotics in particular have been described as like being in a drug prison or a living hell. Now, what is the fundamental misunderstanding about psychiatric drugs? So the accepted view is that drugs work by correcting an underlying biological abnormality. That is to say, they have a normalizing effect. Sometimes that biological abnormality is said to be a chemical imbalance. Sometimes it is said to be an abnormality of brain or neural circuitry. And sometimes the abnormality is not specified. This idea has been widely promoted by the pharmaceutical industry, who have suggested that their drugs are working by correcting underlying imbalances in brain chemicals. And this advertisement highlights the idea that the drugs are balancing out underlying imbalances. And this way of thinking about psychiatric drugs is what I have called the disease-centered model of drug action. So this is the idea that drugs work by correcting an underlying abnormality or targeting and helping to correct an underlying abnormality. And it is based on the idea, the assumption, that the symptoms of psychiatric disorders arise from abnormal biological mechanisms in the brain, and that the drugs are acting on those mechanisms. So this is the correct way of understanding how drugs work in most of general medicine. So for example, anti-asthma drugs like salbutamol for wheezing, the inhaler, the asthma inhaler, that works by reversing the airways constriction that produces the symptom of wheezing. It doesn't work by targeting the ultimate cause of asthma, but it works on the mechanisms that produce the symptoms of asthma. And painkillers like aspirin and paracetamol similarly work on the mechanisms that produce pain. So this model is correct for most situations in general medicine, but I believe it is not correct when we understand what drugs are doing when we prescribe them for mental health problems. The correct way, I think, to understand what drugs are doing in psychiatry is what I have called the drug-centered model. And I have called it this to emphasize that drugs are drugs. And drugs are substances, are chemicals, which change the way that the body normally works. So the drug-centered model suggests that drugs create an abnormal or altered state of the brain. And sometimes these alterations produce useful effects when they interact with the symptoms of psychiatric disorders. So for example, alcohol can reduce feelings of social anxiety, because one of the effects of the changes produced by alcohol in the brain is a lessening of social inhibitions. In medicine, the effects of opiate analgesics can also be thought of as working partly in a drug-centered way. So opiates have some direct effects on pain mechanisms, and that is a disease-centered action. But opiates also are mind-altering drugs. They are psychoactive drugs. And one of their characteristic effects is to induce a state of emotional indifference. So people who have taken opiates for pain often say that they still have some pain, but do not care about it anymore. And that aspect of their effect is a drug-centered effect. So the drug-centered model highlights that psychiatric drugs are psychoactive drugs. That is, they are substances that change the way the brain normally works. We normally think of psychoactive drugs as being recreational drugs or recreational substances like alcohol or cocaine. But psychiatric drugs also change the brain and thereby produce altered mental states. That is, they produce changes in normal sensations and thinking and emotion and behavior. They also change other body systems and produce physical changes too. And these are often linked with the mental changes. So a drug that produces sedation, for example, has physical and mental effects. Drug-induced sedation has both mental and physical components. So drugs change the normal state of the body, and psychoactive drugs change the normal state of the brain. And these changes are manifest in changes in mental activity and behavior and physical functioning. And obviously we're very well familiar with this when we think of a drug like alcohol. But drug-induced changes happen in different ways and at different times, and that's important to be aware of. So if you take a drug just one single time, it will produce some immediate changes, and in some cases there may be some permanent changes, although this is not common. If you keep taking a drug, if you take it continuously day after day, then the body reacts to the presence of the drug, and so the effects that it has may change. And because of this, you will also get withdrawal effects when the drug is stopped. And sometimes after the drug is stopped, there will be permanent changes. There will be changes the drug has produced that do not normalize when it is stopped. And all these changes occur at the level of the body or the brain, but are manifest in physical and mental changes or symptoms. So, to give you an example of these different effects, this is how you would think about the effects of benzodiazepines. They have immediate effects, which are mediated by increases in GABA activity and consist of sedation and mental and physical relaxation. In the long term, if you keep using them, the GABA system adapts so that these immediate effects are reduced. It has been suggested that with long-term use of benzodiazepines, sometimes people can become even more anxious than they were before they started taking the drugs, and that this effect may be caused by a further decrease, a further adaptive decrease in GABA activity. We also know that long-term use is associated with cognitive changes and a possible increased risk of dementia. We don't know the mechanism for that. When you stop taking benzodiazepines, you experience withdrawal symptoms, and these are caused by the decreased GABA activity in the body, in the brain, which is no longer opposed by the drug. And we also know with benzodiazepines that when you stop taking them, some people will have persistent symptoms, persistent problems such as anxiety, but also physical symptoms such as tinnitus and hyperesthesia, heightened sensations. And we do not know the mechanism for this, but it appears that some of the changes induced by benzodiazepines do not normalize in everyone when they are stopped. We can think of antipsychotics in the antipsychotic symptoms in the same way. I won't go into this in detail, but just to highlight that the tardive dyskinesia, which we know is caused by long-term antipsychotic use, is possibly caused by this increase in dopamine activity, which is an adaptation to the presence of the drug, and which we know can continue sometimes after the drug is stopped, and therefore suggests that the drugs have permanently affected or changed the functioning of the brain. You will notice there are lots of question marks in these tables because there are many things that we do not know about the mechanisms through which drugs work, through which drugs produce these different effects. Okay. Historically speaking, drugs, psychiatric drugs, were understood as working according to a drug-centered model up until the 1950s. This is an advert for amphetamines, which were prescribed for depression and lethargy in the 1930s and 40s. And this advert suggests that the drugs would make you energetic and confident. In other words, it emphasizes their stimulating properties. This is an advertisement for barbiturates, which clearly demonstrates their sedating properties. When antipsychotics were first introduced in the 1950s, they were initially regarded as being special sorts of sedatives. They were referred to as neurological inhibitors, then as neuroleptics, which means something similar, and also as major tranquilizers. In other words, they were understood at first to work according to a drug-centered model. This is an advertisement showing how their tranquilizing properties were emphasized. But over the course of the 1950s and 60s, they came to be seen as working in a more targeted or specific manner. So psychiatric textbooks start to refer to how antipsychotics, for example, do more than tranquilize. And by 1970, they were regarded as working in a disease-centered way by targeting the biological basis of psychiatric symptoms. Here is an advertisement for an antipsychotic drug called Mellaril, the same drug as this, but this advertisement is emphasizing their targeted action. There is a similar story with antidepressants. Early antidepressants were described as being similar to stimulant drugs. But by the 1960s, antidepressants were described as acting more specifically than stimulants, as being drugs that could specifically target depressive symptoms, as in this advertisement for imipramine. So the changes in drug classification and terminology reflect this change in thinking about what drugs do. So before the 1950s, drugs are thought to work according to a drug-centered model. So they are categorized, they are classified according to the sort of changes they are thought to produce. So they are classified either as sedatives or stimulants. From the 1950s onwards, drugs start to be named and classified according to the disease they are thought to treat. So nowadays, we talk about antipsychotics and antidepressants and anxiolytics, etc. And this transformation in thinking about what drugs do does not occur because of evidence for the disease-centered model. There was not and is not any significant support for the disease-centered model. First of all, it's important to appreciate that placebo-controlled trials do not distinguish between whether a drug is working according to a disease-centered or a drug-centered model of action. And ideas that mental disorders are caused by abnormalities of brain chemicals that can be reversed by drugs have not been substantiated. So there are some references for articles that provide critiques of the dopamine hypothesis of schizophrenia and the monoamine hypothesis of depression. So I want to spend the rest of my time thinking about what the drug-centered model of drug action means in practice. What does it mean about how we should or when we should use psychiatric drugs? So let's think first about antipsychotics. So the first question we need to ask when we are deciding if these drugs will be useful, and if so, in what situation, the first question we need to ask is, what sort of mental and behavioral alterations do antipsychotics produce? So we know from animal and volunteer studies that antipsychotics are mainly sedative drugs that reduce movement and impair attention, slow up reaction times, impair coordination and intellectual abilities, and reduce spontaneous activity. And subjectively, people experience sedation and feelings of emotional flattening or indifference and reduced motivation and initiative. These are quotations from patients that say the same thing. People describe feelings of mental and physical stagnance, feeling emotionally empty after they have taken antipsychotics. The French psychiatrist Pierre Denecker proposed that early antipsychotics worked because they produced a mild form of Parkinson's disease. He suggested in particular that the emotional suppression or indifference they produce reduces the impact of psychotic symptoms. So he said, patients simply lose interest in their delusions. Okay. This cartoon, I think, illustrates the effects of antipsychotics very well. It shows the exciting world of psychosis, this exciting but dangerous world of psychosis, and compares it to the sort of grey normality that is induced by antipsychotics. Oliver Sacks, the neurologist, his brother had schizophrenia, and his brother described the feeling of taking antipsychotics as feeling rottenly normal. So when we understand that that is the sort of effect that antipsychotics produce, we can understand that they may be useful to suppress acute psychotic symptoms, particularly by reducing people's emotional distress and emotional investment in their symptoms. But I also think that you immediately see that the benefits of long-term treatment are less obvious. Randomized controlled trials show that discontinuing antipsychotics is associated with higher rates of relapse than continuing treatment, than what we call maintenance treatment. But if you follow people up longer term, longer than most of the randomized trials do, you see that the rates of relapse equalize. And this long-term follow-up study of a trial of a gradual process of discontinuation of antipsychotics showed that people who were randomized to discontinuation were more likely to recover than people randomized to maintenance treatment. We also know now that antipsychotics cause brain shrinkage. There are 2 animal studies that show this very convincingly now. So I think that we can say that we do not yet know the risks and benefits of starting long-term antipsychotic treatment. We are not fully clear about the outcome of a gradual discontinuation of antipsychotics. There is evidence that for some people, long-term treatment may do more harm than good. And this is why I am running the RADAR study to try and produce more evidence on this. So the RADAR study is a study of gradual reduction and discontinuation of antipsychotics in people with schizophrenia or psychosis. So I just want to say a couple of words about antidepressants and then I will finish. So again, the first thing we need to know about antidepressants is what sort of mental and behavioral alterations do they produce? There is not very much evidence about this, is the first thing to say. But the evidence that we have suggests that tricyclic antidepressants are strongly sedating and cause associated cognitive impairment. But unlike benzodiazepines, for example, the sedation is not particularly pleasant. People generally don't like them. They cause dysphoria. SSRI antidepressants have more subtle effects. They are not as strong in terms of their psychoactive effects. They do seem to produce a state of emotional numbness in people, and this is associated sometimes with reduced libido and other sexual dysfunction, and a degree of lethargy, particularly with longer-term use. On the other hand, some younger people particularly can experience agitation when they start on these drugs, which may be associated with suicidal impulses and aggression. So the question is, are those effects likely to be helpful in someone with depression? So it may be that the emotional numbness reduces the intensity of people's emotions, and that might reduce the intensity of depression. But antidepressants are also likely to have placebo effects and amplified placebo effects because they are active drugs. And when you compare antidepressants to placebo, there is very little difference between them. So in terms of the standardized mean difference, the difference is 0.3. That difference is found in all the different meta-analyses of antidepressants. And this equates to around 2 points difference on the Hamilton rating scale for depression. The Hamilton rating scale scores a maximum of 54 points. A 3-point difference is not considered to be to represent any change if you look at the clinical global improvement scale. On this scale, you need 8 points difference on the Hamilton scale to register as showing minimal improvement. These are the results from the STAR-D study. This is the biggest ever study of antidepressants with 4,000 people. Less than 100 people took antidepressants, got better and stayed well and stayed in the trial for 1 year. And they were all receiving optimal antidepressant treatment and optimal therapeutic care. So it seems overall that the benefits of antidepressants are very minimal or non-existent compared to a placebo. So I think I'm going to just stop there and just conclude. So what I am saying is that we fundamentally misunderstand what psychiatric drugs do. We need to appreciate the way that they change normal physical and mental functioning in order to decide how to use them wisely. So thank you very much. I will finish there.
The first part I want to talk about is antidepressant withdrawal syndrome and its management. And maybe someone will give me a signal when there's 10 minutes left of the session, so there's some time for questions, see how I go. So antidepressants are widely used in England. I couldn't find the data for Argentina, but about 15% of the population in England are on antidepressants. About half of them are on it for more than 2 years. And the question is, what happens to these people when they want to stop their antidepressants? So until very recently, NICE, which is the major guide giver of medicine in the UK, said that discontinuation symptoms, another term for withdrawal symptoms, are usually mild and self-limiting over about 1 week, but can be severe if the drug is stopped abruptly. But there's a different story on websites around the world. So there are Facebook groups, peer support websites, a number of different places where people go to talk about how difficult it is to come off antidepressants and to get advice from one another. And there are tens of thousands of stories about severe and long-lasting symptoms that come from stopping antidepressants, including symptoms like brain zaps, dizziness, and depression. And it's very common that these people have gone to their doctors and been told that there can't be a problem with coming off these drugs. It should be mild and self-limiting, like the NICE guidelines say. And so this can't be problems from antidepressants. It must be their original illness coming back. But many of these patients say it felt different from my original condition, for example, having dizziness or brain zaps. So they lose faith in their doctors and they end up on these websites asking people for advice. And they end up concluding that coming off their medication much more slowly than they've been suggested by their doctors makes the process easier, although still not that easy. The first scientific attempt to look at how common withdrawal symptoms are, how severe they are, and how long they last only occurred 2 years ago. This was the first systematic review to look at this topic. And what they found was about a handful of studies, about 24 studies. And this is an example of one such study done about 20 years ago, where people on either fluoxetine, sertraline, or paroxetine were taken off their drugs for 5 to 8 days, and their symptoms were measured using a standard measure of withdrawal symptoms called the DES, and this lists all the different symptoms that they found. If you had more than 4 symptoms, they defined it as having a withdrawal syndrome, and you can see worsened mood, irritability, agitation, dizziness, for example, occurring very commonly in sertraline and paroxetine, and quite commonly in fluoxetine. And so overall, about 2/3 of patients had withdrawal syndrome coming off sertraline or paroxetine, and less for fluoxetine. And on average, it was about half of patients. So this systematic review put together all these studies, and what they found was that about 56% of all patients will experience withdrawal symptoms. And there were very similar answers depending on whether they looked at only randomized controlled trials or also observational trials or surveys. They were all more than half, with some variation between them. It's also interesting to look at the duration of treatment versus the incidence of withdrawal symptoms. So if you plot the average period of time that people are on these, in this case, paroxetine, versus how many people get withdrawal symptoms, you see quite a smooth curve. So if people are only on them for a few months, about a third of patients will have withdrawal symptoms. But by the time you're on them for more than 3 years, about 2/3 or 3/4 of patients will have withdrawal symptoms. And this is similarly true for other drugs. For example, escitalopram, a similar shaped curve, and also for fluoxetine, although both are a little bit less than paroxetine. This seems to also hold for severity of withdrawal symptoms. So in this graph, duration of time on the drugs is plotted against the incidence of withdrawal symptoms, that's the top line, but also the severity. So this bottom line is people who said their symptoms were either moderately severe or severe. And you can see the longer people are on these medications, the more, the greater proportion report having withdrawal effects that are severe or moderately severe from the drugs. And about half of people report severe or moderately severe effects by the time they've come off drugs after 3 years of use. The duration of withdrawal symptoms has the poorest evidence for it. You can see a plot of duration of antidepressant use versus duration of withdrawal symptoms here. And there's a suggestion that it increases, that withdrawal symptoms increase along with duration of use, but there's such few data points. Although it does seem clear that people who are on the drugs long-term for several years can have symptoms that last for many months or more than a year. So although the data is limited because there's only about 25 studies, it seems that about half of patients will have withdrawal symptoms. About half of those patients may have severe withdrawal symptoms, although this may be a slight overestimate because it's taken from surveys, so it may have captured people with more severe withdrawal symptoms than average. The duration is more difficult to ascertain, but there's many studies in which patients have withdrawal symptoms that last for several months or longer. So in response to their own investigation, the Royal College of Psychiatrists in the UK issued an alert to doctors and patients in May of last year, calling for people to become more aware of the risk of withdrawal symptoms from stopping antidepressants. In their report, they said that withdrawal symptoms can be severe and long-lasting, and that patients who are considering antidepressants should be told of the risk of severe and long-lasting withdrawal symptoms in some patients when they are considering starting them. They also pointed out that it can be difficult to distinguish withdrawal symptoms from antidepressants with relapse of the underlying condition, and that people should take a special care to try to distinguish withdrawal symptoms from relapse of their condition. So maybe just briefly, antidepressant withdrawal syndrome consists of psychological and physical symptoms that occur when you stop or reduce an antidepressant. In the past, the term antidepressant discontinuation syndrome has been used, but withdrawal syndrome is the more accurate scientific term. There are many symptoms. Some of the more common ones involve dizziness, insomnia, impaired concentration, fatigue, headache. There are also mood symptoms like low mood, irritability, and anxiety, and there are sensory symptoms, electric shock-like sensations in the head or in the body, sometimes called electric zaps. There are also gut symptoms like nausea, vomiting, and diarrhea, and there's also an increase in suicide attempts in the 2 weeks after stopping an antidepressant. Withdrawal symptoms from antidepressants are often misdiagnosed as relapse, with medication recommenced, but it's not known how often this occurs. There are some things that can help to distinguish relapse from withdrawal symptoms. So withdrawal symptoms have a quick onset, often after a few days after stopping the medication, except fluoxetine, which has a long half-life. That's different from the relapse you might expect weeks or months afterwards. There are specific symptoms in withdrawal, things like dizziness, electric shocks, or other symptoms not present in the patient's baseline condition. And also, symptoms can often resolve reasonably quickly on starting the antidepressant again in hours or a few days, compared with the weeks you may expect for a response from an antidepressant. It's recognized, withdrawal symptoms are recognized for all classes of antidepressants, and there are a few things that determine its severity. The longer you use antidepressants, the more likely it is to be severe. Antidepressants with short half-lives, like paroxetine or venlafaxine, have more severe withdrawal symptoms. And if an antidepressant is stopped abruptly rather than tapered slowly. So based on this evidence, NICE has updated its previous guidance to say there is substantial variation in people's experience with symptoms lasting much longer, that is withdrawal symptoms lasting sometimes months or more, and being more severe for some patients. And so this was a big step forward where withdrawal symptoms were recognized to be possibly severe and sometimes to last for years. Management of antidepressant withdrawal syndrome. So the current NICE guidance says that the way to manage withdrawal symptoms is to gradually reduce the dose, normally over a 4-week period, although some people may require longer periods, particularly with drugs with a shorter half-life. But there is no guidance on how to reduce the dose, what gradually means, and what a longer period may entail. So we wrote a paper last year in the Lancet Psychiatry, reviewing the literature on tapering antidepressants. And we concluded that there are 4 important principles. Tapering rates should be individualized for each person. Tapering should be slow, generally months and sometimes years. And tapering should go down to very low levels of drug before the medication is stopped. And lastly, the tapering should probably follow a hyperbolic pattern, which is similar to saying sequential halvings of dose. For example, going from 20 milligrams to 10 milligrams to 5 to 2.5 to 1.25 to 0.6 before stopping. And I'll explain why we thought that. This is a graph from PET imaging of the brain. So this is neuroimaging. It shows the relationship between the dose of, in this case, citalopram, and the effect on the serotonin transporter, the main target of antidepressants in the brain. And you can see the relationship between dose on the x-axis and effect on the serotonin transporter is not a straight line, but rather a curve. So when there's not much drug around, every extra milligram of drug has a very large effect on the brain, so the effect goes up steeply. But once you reach therapeutic doses around 20 milligrams, every extra milligram has less and less effect on the brain. And this can tell us something about how to stop antidepressants. Many doctors advise their patients to make linear reductions, that is to go from 20 to 15 to 10 to 5 to 0, which sounds sensible. But if you look at the effect on the brain, the reduction from 20 to 15 causes a very small decrease. From 15 to 10, a larger decrease. From 10 to 5, larger again. And the last reduction in dose from 5 milligrams to 0 causes an enormous reduction in effect on the brain. And this corresponds to the increasingly severe withdrawal symptoms reported by patients as their dose gets lower. This understanding also provides a solution. It makes more sense to reduce antidepressants so that their effect on the brain is reduced by linear amounts rather than based on linear amounts of dose. What this means is that the drug has to be decreased by smaller and smaller amounts as the dose gets smaller, and the final dose before stopping completely needs to be very small. So this graph, which gives 20% reductions of effect on the brain, means you need to use doses of citalopram of 19, then 5.4, then 2.3, then 0.8 before stopping. But it's a simpler approximation is halving the dose of the drug. For example, 20, 10, 5, 2.5, 1.25, 0.6, 0. It just so happens that the Royal College of Psychiatrists has just launched its new guidance on stopping antidepressants this week. It recommends patients who have been on antidepressants for more than a few weeks taper off over months or longer. They suggest going down to very small doses, less than 1 milligram, before stopping. And they recommend going down in smaller and smaller sized reductions. Here is an example of a rapid reduction schedule from the Royal College's guidance. So this is reducing citalopram, and this is rapid because the dose is halved every 2 to 4 weeks. And you can see the final dose before stopping is very small, 0.6 milligrams, and patients will need a liquid version of the drug to achieve that. And overall, stopping the antidepressant like this will take about 3 to 6 months for people who have been on the drug for more than a few weeks. A slower reduction schedule is given, for example, for paroxetine. This involves reducing the dose by 10% every 2 to 4 weeks. And you can see that the 10% is calculated on the most recent dose. So it becomes smaller and smaller with each step. So initially you go down by 4 milligrams, then you would go down by 3.6 and so forth. And it gets smaller and smaller as you go down. There will be about 40 steps to get down to about 0.6 milligrams before stopping. And this regime will take about 2 to 3 years because paroxetine is a particularly hard medication to come off from. And here are some references to follow up. This is the position statement from the Royal College of Psychiatrists on withdrawal, their guidance on how to stop antidepressants, and some of the papers mentioned here. I think I don't have a lot of time left, so I'll very quickly go through some ideas about esketamine, which you may know has been recently approved as a treatment for treatment-resistant depression. A lot of psychiatrists have promoted this drug as being a brand new type of drug. It's not just the same old steam engine, it works in a different way. Ketamine has been around for many years. It was used as an anesthetic agent and it causes a trance-like state, pain relief, sedation, and memory loss. It's problematic because it causes psychotic symptoms, and so it's generally used in emergency circumstances or for animals. Most of the problems from ketamine arise from the increase in heart rate and blood pressure it can cause, and that means it can lead to heart failure and heart attack, more likely in people with pre-existing risk factors, and this means that blood pressure and heart rate are monitored carefully. It's also been a party drug. It's been known as psychedelic heroin because of its psychedelic effects. It produces a dissociative state, a sense of detachment from one's physical body and the external world, often called the K-hole. Many people enjoy this, and it frightens others. It's normally ingested by snorting. A recreational dose is 60 to 250 milligrams, and it rapidly causes tolerance, withdrawal symptoms, and addiction in some people. It's very popular in the UK. It's been associated with more than 100 deaths, including from traffic accidents and suicide. This is probably because ketamine impairs hand-eye coordination and balance, increasing the risk of traffic accidents. And in fact, in Hong Kong, where it was very popular, almost 1/10 of all fatal car accidents involved ketamine. Another problem is ketamine bladder, which is an ulcerative cystitis, which can lead to perforation of the bladder and inability to urinate and can require catheterization. It can also cause cognitive problems and depression in the long term. The withdrawal symptoms of ketamine include anxiety, trouble sleeping, and depression. It's been known that intravenous ketamine can reduce depression scores like other anesthetics like propofol or nitrous oxide. And some people have suggested this may be similar to the psychoactive effects that make this drug popular with recreational users. So S-ketamine is one of the two mirror image molecules of ketamine. It's twice as strong, like escitalopram is twice as strong as citalopram. It's been approved for 50 to 80 milligrams, and given its double strength, this is very similar to the recreational doses people use, although some people use higher doses than that. And it's delivered in the same way through a nasal spray, similar to the snorting used recreationally. There were 5 studies that were submitted by Janssen to the FDA for approval. 3 short-term 4-week studies, 1 withdrawal study, and 1 safety study. And I'll talk about each briefly. First of all, the people who were included in the studies were people who had major depressive disorder, have failed 2 antidepressants, and they could both be SSRIs. You were excluded if you had psychotic symptoms, if you had a history of suicidal behavior in the last year, or suicidal ideas in the last 6 months. You were excluded if you had any alcohol or drug use, and you're excluded if you had not responded to ketamine, S-ketamine, or ECT in the past, and there was no requirement for psychotherapy. Some have suggested that this is not consistent with most clinicians' experience of treatment-resistant depression. This seems somewhat more mild. The MADRS was used to detect depression out of a score of 60. So normally the FDA requires 2 positive short-term studies, that is statistically significant studies, but they relaxed the rules for S-ketamine and allowed 1 positive short-term study and 1 withdrawal study because the company could not produce 2 positive short-term studies. There were 3 short-term studies performed. 2 showed no statistically significant difference between saltwater spray, placebo, and S-ketamine. 1 trial showed a statistically significant difference between S-ketamine and placebo. In this trial, placebo reduced MADRS score by 17 points, and the S-ketamine reduced the MADRS score by a further 4 points. So just to show this quickly, these are the 2 non-significant trials. You can see the black line is placebo, a reduction of 15 points, and the 2 doses of S-ketamine had no significant difference from placebo, and a similar finding in older patients. This is the positive trial. You can see the placebo produced a 17-point reduction, and S-ketamine produced an extra 4 points on the MADRS. There are two issues with this study. Number one, S-ketamine causes a metallic taste in the mouth and also causes psychoactive effects like dissociation. This would tend to let patients know which drug they're on, and expectation effects might increase the effect of the drug. There's also the question of what is a clinically significant difference. And similar to the slide that Joanna showed, it's been worked out what a MADRS change versus clinical impression from a doctor constitutes. And for a minimal improvement to be registered, a MADRS reduction of 7 points is required. And so a 4-point reduction is less than would be detected as a minimal improvement. You need to have a 16-point reduction to be much improved, which is what placebo achieved. And it's worth noting that the S-ketamine effect of 4 points was about 1/4 the size of the placebo effect. Because they couldn't produce two positive studies, they were allowed to do a withdrawal study. That follows this pattern. Patients were given S-ketamine for 12 weeks. If they responded, that is, they halved their MADRS score, they continued, and they were then randomized to either continue their S-ketamine or to stop abruptly and be put on nasal saltwater spray. And their MADRS score was measured for the next year. And this is what they found. People in placebo relapsed more often, and you can see that the difference occurred over the first 30 days. After that, the lines came closer together until they got very close. There are a few issues with this study design. First of all, only patients who responded to S-ketamine were included, meaning it's an enriched population. Number two, S-ketamine has clear psychoactive effects, including dissociation. So patients will know that their treatment has stopped in the placebo group. So this would tend to unblind patients. And perhaps most importantly, S-ketamine is known to have withdrawal effects, including insomnia, anxiety, and low mood. It was stopped abruptly, and so it was likely to cause withdrawal effects. These would have been measured on the MADRS, which includes all of these domains: sleep, mood, anxiety, and appetite. And so withdrawal effects could have been misclassified as relapse. The fact that most of the relapses happened in the first 4 weeks is consistent with this, because this is when withdrawal symptoms are most likely to occur. You can see the overlap between ketamine withdrawal symptoms and the MADRS here, and withdrawal symptoms were not reported for this study. There was also one site that was seen as an outlier, and if you remove it, in actual fact, after a few months, there's no difference between the two arms of the study. I'll just talk for 2 minutes about safety. So there were 6 deaths in these trials. All 6 deaths occurred in the S-ketamine arm, and there were none in the placebo arm. These deaths were 3 suicides, 1 fatal motor vehicle accident, 1 person died of heart and lung failure, 1 died of myocardial infarction. What's interesting about the causes of these deaths is they're all recognized from ketamine use either in anesthetics or recreationally. The blood pressure spikes can cause heart attacks and heart failure, and impaired hand-eye coordination and dissociation can cause car accidents. And there were, in fact, 5 car accidents in the S-ketamine arm, one of which was fatal, and none in the placebo arm. There has been a lot of speculation about what caused the suicides, perhaps withdrawal effects, perhaps psychotic or psychedelic effects, or flashbacks. This is an account of someone who used esketamine. There are many positive and negative accounts. This man talks about feeling that he is spinning, that he has a headache, that he couldn't move, that he began crying for his mother, and that he felt scared, and the effects lasted for longer than a day, which gives some context to the use of this drug. There were also many other side effects. Half patients experienced dissociation, a third dizziness or sedation. 10% had significant blood pressure rises, and 10% had bladder-related problems reminiscent of ketamine bladder. Very briefly, in the long-term safety study, 15% of patients developed new onset suicidal ideas in the esketamine group, and 6 of these patients attempted suicide. This is notable because this group of patients was selected for not being suicidal. They had to have had no suicide attempts for 12 months and no suicidal thoughts for 6 months. So this increase is somewhat concerning. Similar problems have been reported by doctors in the US since the drug has been released over the last 12 months. There's been an increased reporting of dissociation, sedation, feeling drunk, suicidal ideation, and also completed suicide. And the authors of this study concluded that the safety of this drug requires urgent clarification. I'll leave it there for some questions. Thank you.
Someone concerning antipsychotics, someone mentioned the studies by Jari Tionen from Finland, which have used big databases and appear to be suggesting that that if you take antipsychotics long term, you are less likely to die. Now, this is a very strange finding because there are also studies that show that antipsychotics are more likely to increase mortality. And we know that they adversely affect the cardiovascular system, as well as many other systems that might increase mortality. There are several critiques of the Tionen studies. I don't know whether it's been published yet, but Robert Whitaker from the Mad in America website wrote a very good critique on his website. And he points out how their method of analysis, that is using patient years to calculate death rates, inflates the death rates on off drugs and decreases the death rates on antipsychotics artificially, and is basically a completely invalid way of assessing mortality and leads to spurious conclusions, inaccurate conclusions. There is also the issue that that people who take long-term medication, who take it carefully and regularly, are more likely to be healthy than people who stop it or go on and off it. This has been shown in other studies. There is a healthy complier effect, which these studies are probably detecting. And finally, Jari Tionen, the author, and his co-authors have numerous financial links with drug companies and have produced these studies showing these curious results for many years now. So that was to pick up that point. On the more general point about the long-term use of psychiatric drugs, particularly antipsychotics, I want to say that I think long-term use is probably useful for some people, particularly people who have chronic ongoing symptoms. But I also think it is likely that there are some people who have occasional episodes of psychosis for whom the harmful effects of long-term treatment are greater than any benefits they will get from it. And I think that starting and stopping antipsychotics, there is evidence that starting and stopping antipsychotics leads to more relapses, because discontinuation makes people vulnerable, more vulnerable to relapse than they would normally be. And someone also mentioned duration of untreated psychosis, DUP. I don't know if the initials are the same. So duration, it has been suggested that starting antipsychotics early will prevent a process of brain degeneration. And this is completely untrue. The evidence that this is based on is evidence that people who have long-term schizophrenia show a reduction in their brain size. But all the people in those studies were using antipsychotics. And we now know from the animal studies that the antipsychotics are causing at least part of that brain reduction.
I'll answer one question. It's about Joanna's material, but I'll just pop in there. Someone has said that isn't wondering an example of reverse causation, because people who are less severely unwell will stop their medication, but Wondering was a randomized controlled trial, so patients who were randomly assigned to either continue their medication or to come off it slowly. So it's not explained by reverse causation. It was the patients who came off their medication slowly, who in the long term had a greater recovery rate. That is, they were more likely to be working or studying or in relationships or living independently, about twice as often as those who continued their medication.
So there's a lot of evidence on dopamine and psychosis, and most of it is negative, or dopamine and schizophrenia. Most of it is negative. There are some recent studies that suggest there may be increased activity in the dopamine system in people who are acutely psychotic. But the trouble is that dopamine is also associated with stress, with movement, with hunger, with many things. And these things have not, with arousal, with increased arousal, and these things have not been properly controlled for in these studies of the links between dopamine and psychosis. So overall, there is still no evidence that dopamine is specifically related to psychosis, although it may be increased in a situation where someone is aroused and disturbed. The Katie study, yes. Yeah. I mean, so the question, someone makes a very good point about the Katie study, which was a large US study comparing different antipsychotics. And they point out that the older antipsychotic perfenazine was as effective or better than the newer antipsychotics. But nevertheless, people have continued to prescribe the new atypical antipsychotics. So I think the questioner is suggesting that our use of drugs in psychiatry is influenced by marketing and is not necessarily rational or dictated or determined by evidence, and I would agree.
So S-ketamine has been approved by the drug regulatory agencies in America, in Europe, and in Britain. The account of the regulation of it in America is very interesting. The FDA asked for 2 positive trials. A couple of years later, Janssen came to them and said, we can't produce 2 positive trials. And they agreed together that they would have 1 strongly positive short-term trial and 1 withdrawal trial, which was a big break from the normal rules of the FDA. A year later, the Janssen came back and said they cannot produce a strongly positive trial, and Janssen agreed with the FDA that they could produce any statistically significant short-term trial and a withdrawal trial. So they negotiated what Janssen would produce together, and it's in the public documents of the FDA. The MHRA and the EMA seem to have followed what the FDA did. However, that's extremely different from what national providers of health decided. So in Denmark, in Sweden, in France, and at the moment in the UK it's being considered, the people who have to actually approve the medication to be given to patients have generally said no to the medication. They've generally said it's not a very effective medication, it's very expensive, and the long-term safety and long-term effectiveness is not proved. And most countries have said they will not fund it, or it will be reserved for people who have failed 4 or 5 drugs and therefore not used very much. So there's been quite a difference between what the national bodies who provide healthcare, who seem to look at these things more carefully and more stringently than the drug regulators, who seem to have a lower bar. And in fact, if you look at what the bar is for the drug regulators, they say a drug has to be safe and effective, but effective from their point of view means there's a statistically significant difference from placebo, and safety has a relatively loose definition. And I think that's evident in the S-ketamine approval process.